Good morning, everybody. It's my pleasure and honor this morning to introduce our Grand Round speaker, Dr. Reshmi Srinath. Dr. Srinath is an associate professor in the Division of Endocrinology, Diabetes, and Bone Disease at the Icahn School of Medicine, and she directs Mount Sinai's Weight and Metabolism Management Program. Her interest in metabolism, nutrition, and prevention of metabolic disease started in college, where she was a Division I tennis player, and led her to pursue a career in medicine and to specialize in endocrinology. Dr. Srinath graduated from the University of Connecticut School of Medicine. She then completed her residency in internal medicine at Duke and a fellowship in endocrinology, diabetes, and metabolism at Johns Hopkins. She's been on faculty at Mount Sinai since 2015 and specializes in the prevention and treatment of obesity, diabetes, and other metabolic complications. Her clinical research seeks to understand the underlying phenotypes of obesity, as well as the factors driving the development of metabolic disease and response to interventions. Dr. Srinath began developing the Mount Sinai Weight and Metabolism Management Program in 2015. She approaches obesity medicine by evaluating secondary causes of weight gain and addressing the metabolic complications of obesity, as well as utilizing basal metabolism testing and exercise testing to personalize a patient's meal plan and exercise regimen. Since developing the program, she's become a referral source for physicians across the Sinai system and regionally for medical management of obesity in patients with diabetes, heart disease, respiratory disease, complex pain disorders, and joint diseases. She also has taught on obesity to medical students, residents, fellows, and faculty across the tri-state region and nationally. And it's my pleasure this morning to welcome her to the Department of Family Medicine and Community Health. Dr. Srinath.
Thank you. Thank you so much, everyone. Good morning. Happy Friday. We'll do sort of obviously introductions in terms of just disclosures. I did have some research support from Dexcom doing a study looking at placing Dexcoms on patients with weight and obesity, and that is finishing up, and excited to present some results in the coming year. In terms of today, talking about weight management, there's a lot of things and topics to address, but briefly, just one, sort of addressing sort of the change in framework for how we address weight and how we address obesity in the clinical realm. Number two, I'll briefly talk about the role of diet lifestyle. I think that is a conversation in itself and another talk. And then really just to focus on talking about the medications, anti-obesity pharmacotherapy, and the role of bariatric surgery briefly, and how we can sort of put this together. Definitely will leave room for questions because I'm sure there will be many. So this is, this is newer data, but not new. This is 2023 from the CDC, just showing growing, prevalence of obesity. We know that, states highlighted in dark red, unfortunately, have prevalence of 45 more percentage, where, residents have a BMI over 30. These numbers continue to grow, and that is concerning because it's played out with COVID, it's played out with different, epidemics. So, we do want to continue to monitor this, and this data is important. In terms of how we can address this, so, really the push started way back in 1998. The National Heart, Lung, and Blood Institute created sort of their clinical guidelines. How do we address weight? That was really then elaborated on in 2013 when there was a guideline that came out from the American Heart Association, the American College of Cardiology, and the Obesity Society. And in more recent years, I would really say 2016, the guidelines from our American Association of Endocrinology put out a guideline, which I'm on a committee, we're updating that now, developing what's called a clinical algorithm. And so there's growing interest in sort of how do we address this and how do we frame the conversation with patients. The big change is really thinking about weight, not just as a physical number. So, many patients come to us and they're fixated on this is my weight, this is where I was. We want to think about this more globally in a context. And there's been a phrase coined by the American Association of Clinical Endocrinology called ABCD. The idea of this behind this is adiposity-based chronic disease, where we think about not just the weight, not just the number, but thinking about this in a physical context, looking at cultural, environmental factors, and really looking at what are the complications of the weight and how that can change how we address it. And this sort of shift away from weight and BMI was adopted last year. Actually, the AMA put out a policy July of 2023, really recognizing that BMI is not a perfect marker. There is some exclusion here. It was developed from data collected many generations ago. And there are other measures, that can be helpful, including measuring waist circumference, measuring body composition, obviously looking at metabolic genetic factors. Obviously, in a clinical setting, that's challenging. I would say weight and BMI are the easiest measure you can get. But I do think that we have to take it into sort of a big picture and say, yes, we have our weight, we have our BMI, but we have other things that we can collect if we can, and that can help drive the conversation. What we're trying to move towards is, rather than a conversation driven by what a patient's weight is, more towards a what's called a complication-centric approach. What this means is essentially you see a patient, you're gathering as much data as you can, their weight, their BMI, if you can measure a waist circumference, wonderful. And then really looking at what are the metabolic complications? Does this person have diabetes? Does this person have heart disease? If someone has at least one moderate to severe complication, such as diabetes or heart disease, they have more severe obesity. And this is someone who's going to want to be treated more aggressively than someone who's otherwise metabolically healthy. So again, thinking about this towards a more complication-centric approach, and then addressing that using lifestyle, pharmacotherapy, and if needed, bariatric surgery. And what are our weight loss goals? So ultimately, we know even if someone loses 5% of their body weight, that will help. So 5% we know can help with blood pressure, can help with improving some of their blood sugar control. But I would argue that getting someone to lose at least 10 or ideally 15% of their body weight is helpful. And in these situations, I don't tell them this is my specific number, but I'm looking at more setting short-term goals and really seeing how they're progressing. And yes, if I can get them down 10%, I can see improvement in their diabetes control. I can see improvement in their liver markers. I can see improvement in cardiovascular disease risk markers. And if we can help them lose more than 15%, we are seeing improvement in mortality. We're seeing remission of some of these metabolic diseases. So definitely from a spectrum, I would say 5% at a minimum can help a patient. But ideally, if we can help them lose at least 10 to 15%, we know that they will be in a better place overall metabolically. In terms of sort of next steps, so I'm going to briefly talk about the role of diet and lifestyle, and then we'll focus the rest of the talk on sort of talking about medication. So in terms of eating habits, for many of our patients, I do counsel them that to jumpstart weight loss, it does come to our diet. It does come down to creating that initial caloric deficit. We say that's about 500 calories a day reduction. Obviously, if you continue to reduce, at some point you're eating nothing, and that is not sustainable. So definitely, I do get patients who are eating 1,000 calories or less, and I say, stop, please. This is not sustainable. You're struggling. This is also, resetting your caloric rate, your metabolism, and it's not a healthy place to be forever. So definitely, though, incorporating requirements for females, this is equivalent to about 1,200 to 1,500 calories a day. For most men, up to 2,000 calories a day. And we know there are many, many diets out there. I sort of characterize them in different flavors. So we've got the very low calorie diets. Those are less than 800 calories a day. Those are ones that need to be clinically monitored. They're usually more like a meal replacement or protein shakes, things like that. I'm not someone that recommends those in general. And then we got sort of the general low calorie diet. So these all can be between 1,000 and 1,500 calories a day. You can characterize them as low fat. You can characterize them as low glycemic index. You can call them low carb or high protein. We've got the Mediterranean diet. We've got intermittent fasting. So there's so many different varieties here, which all sort of fit that category between 1,000 and 1,500 calories a day. And the question is, which is the best one? So this is actually an older study. I present it just because it's important. It was published in New England Journal in 2008, but it compared low-fat Mediterranean low-carb diets. And as you can see, in the first 6 months, and these patients were all controlled, they were being monitored, their compliance was being assessed. First 6 months, yes, low-carb, those patients lost the most weight in that first 6 months. But then over time, as you can see, everyone sort of reached that plateau or sort of happy place. And those numbers and those lines sort of convene. And so the idea being that all these diets do work. Obviously, it comes down to compliance, ability to maintain that. And the other idea is at some point, everyone reaches that sort of plateau or that place where their body wants to be. And so even with all of these diets, these numbers converge. So it's important to note that all diets are similar. It's really what someone's able to maintain, and looking at sort of the breakdown of food and the calories, that's what's sort of important. There was another study that came out, I believe, last year, just comparing dietary programs and looking at mortality and cardiovascular disease. So this was a meta-analysis. There were 40 randomized controlled trials, and they looked at seven dietary programs. I would say the big ones were Mediterranean, low fat, Ornish, modified fat. So what they were looking at were these different significant outcomes, and highlighted in green are the ones that showed potential for benefit. So number one and number two, Mediterranean low fat, showed potential in terms of benefit, in terms of outcomes of all-cause mortality, cardiovascular mortality, stroke, non-fatal MI. And so these are the two out of all the dietary programs which were felt to potentially have some benefit. So again, this is another sort of larger study showing some data in terms of what dietary programs are beneficial. A lot of patients come to me asking about intermittent fasting. And this, we've been gathering data over the last, 5, 10 years. And, I think for many, it helps because it creates structure to their day. They like having or noting that they can only eat in a specific time frame. But this actually came up last year in the spring, and it sort of, halted some of this interest. And this is actually a abstract presented at one of the conferences. And it showed that 8-hour restricted eating, which is what most of the patients that I follow are doing, if they're doing this, was linked to a 91% increased risk of cardiovascular death. That is very concerning. And interestingly, this was done in NHANES, which is a very reliable population. They followed over 20,000 participants. But what's interesting is it was all based on dietary recall. We do not have a formal manuscript yet or paper. So I'm interested to see what the data is and really how they collected this data. What are the demographics? What was the patient population? Because I think it will be interesting to see how this plays out and what this means. But I will ultimately be clear that for many patients, I will say intermittent fasting helps if it creates structure and they like it. But for those where it creates overeating or binge eating, I don't really like it. And so for most patients, I tell them if you can finish eating at a certain hour, ideally by 8, that's great. But I don't like the idea of really going for more than 16 hours without eating. I think that's actually not a great thing. What we do know is that a healthy eating pattern is really comprised of a variety of fruits, vegetables, whole grains, as you guys know, making sure you're getting a lot of fiber. And I was reading an article yesterday saying that even fiber is just as important as protein. And then really focusing on limiting sodium intake, saturated fats. We know sugar sweetened beverages, alcohol, and thinking about, just timing of when people eat. And so we do know there is some data about when people eat sort of larger meals, more sugar at night, that can impair glucose tolerance more. So I do counsel patients, trying to be mindful of that and what they're eating late at night and how that impacts them. So just some things to keep in mind. Behavioral modification is another crucial part of this. So we know that for many, monitoring their food intake, charting if they need to, looking at short-term goals, saying, okay, I need to lose 50 to 80 pounds. Yes, that's a large number, but if we can set short-term goals, 1 month, 3 months, 6 months, that can help. And yes, some people need psychological help, whether that's working with a psychologist, whether that's working with therapy. I do like Weight Watchers and Noom. I think it creates structure, it creates accountability. Noom is a program which pairs you sort of with a coach, or you're tracking your food intake, but you're also getting input and recommendations. So I do think that Weight Watchers and Noom from that perspective does help create support, and many patients do benefit from that. And not to forget the other part of the equation. So we know that dietary changes jumpstart weight loss. I will say that exercise plays more a role in maintaining weight and sort of keeping weight loss going. We know that our current guidelines recommend at least 150 minutes a week, and that is moderate intensity activity that helps get your heart rate up. That can be walking, that can be biking. But the one point that I will make, and this is something that I really emphasize in all my patients, especially as we get older, is the role of muscle strengthening activity. So at least 2 days of strengthening and toning. And this is across the board. This is if you're trying to lose weight on your own. This is also even more important when you're potentially on medications. And we'll talk a little bit about that as people start losing weight, both with lifestyle intervention or with medications, they're losing fat and muscle mass. And so it's really important that we're incorporating some form of strengthening and toning to maintain that muscle mass because that's what's driving your metabolism. So for those patients who come to me who have tried their best, they're eating as well as they can. They're, trying to comply with exercise, trying to be active. If they have a BMI over 30 kilograms per meter squared or a BMI over 27 with complications, and those complications are listed below. So for commercial insurances, you do have to have these qualifiers of type 2 diabetes or hypertension or hyperlipidemia or sleep apnea or heart disease. So if you have one of these and you have a BMI over 27, certain commercial insurances will cover weight loss medications. There are many commercial insurances that don't cover them, and I've hit that hurdle many times. That number is growing. In fact, I've had a lot of patients who had coverage and then don't have coverage this year. I'll also be mindful that Medicare and Medicaid do not cover these medications at this point, but there are some loopholes, which I'll talk about. The other point I want to make is that when you do start these medications, and this is crucial with any medication really for weight loss, or even for diabetes, it really does require close follow-up. So it's not just a matter of, okay, I'm starting this drug, I'll see you back in 6 months. It really means you need to check in with that person every 4 to 6 weeks. You need to be monitoring their progress. You need to be monitoring them for side effects and also for dosing. And the way these drug companies created some of these medications, you have to titrate the drug every month. And so a new prescription is needed, and that's work in itself. So I think that that sort of follows along with the close follow-up. And this is ideally having a multidisciplinary team, nutritionist, obviously physician, nurse, everyone needs to help and really track these patients and make sure that they're doing okay. Because there can be pitfalls along the way, there can be side effects, and many patients, have concerns, even picking up prescriptions and starting them. So making sure that they're doing the right thing. So this is a list, and this is sort of, you can separate medications in many ways, but these are sort of the single agents that we have. And I'm going to start from the top, and we're going to go through some of these in more detail and talk about them. But one of our oldest ones is orlistat. So orlistat, also known as Xenical, the brand, is a pancreatic lipase inhibitor. You can get this over the counter as Ally. So Ally is 60 milligrams 3 times a day. The brand orlistat, Xenical, is 120 milligrams. What does this do? It helps with appetite. Obviously, what is it preventing? Fat absorption. So there are side effects, gas, flatulence, a lot of loose, smelly stools. I've had some patients who like orlistat and who respond well to it. And, given we have newer medications, we don't use orlistat as much, but I would say as an option that's over the counter, I've had people do well on it, and some people have really liked it because they say it prevents them from eating fatty foods. They feel it. Next, we're going to talk about, phentermine, which is a stimulant first developed in the 60s, which we now continue to use. And then we've got our injections, which is liraglutide, known as Saxenda, semaglutide, which is known as Wegovy, and then tirzepatide, which is brand as Zepbound. So keep in mind, these are the brands that are approved for weight management. The 2 drugs here that I've crossed out are no longer on the market. So lorcaserin was approved in 2015. It's a serotonin agonist. This was actually pulled off the market in 2020. Unfortunately, it was actually a decent agent. It was very mild, but people liked it. Helped with weight loss, but they were doing a study looking at cardiovascular outcomes, and they found that there was an increase in risk of cancer, particularly rectal and uterine cancer. And whether that number was significant compared to placebo, it was significant enough that they pulled the drug back in 2020. And this was, I think, the Camellia study that they were working on. The other medicine that I've crossed out here is called Plenity at the bottom. So Plenity was developed a few years ago. It is a hydrogel capsule, essentially, that was supposed to expand to the size of a cabbage, create restriction in your stomach. You're supposed to take it with 2 glasses of water up to 3 times a day. And really for financial reasons, it was pulled off the market in the last year or so. Not due to adverse effects. There are newer versions of Plenity coming out, which are essentially hydrocellulose fiber, and we're hoping to hear more from those. And then we've got our dual agonists, which are phentermine topiramate, fusimia, and then naltrexone bupropion. So I'm going to go through these a little bit more detail. You can think of them sort of in different flavors. Like you said, we've got pills, we've got injections. You can think of them as sort of more appetite suppressants and more boosters. You can also characterize them, some people say, sort of first generation medications, which are pills, metformin, things like that, phentermine, topiramate, and then you've got more second generation medications, which are the injectables. So I think there are many different ways of describing these medications, but I will say, yes, we have at least 5 to 6 drugs, and there are ways to get these medications, even with having commercial coverage for them. So one medication that's not listed here that I want to talk about briefly is metformin. So metformin, we do use a lot of, but I will mention that there is weight loss benefit. Metformin was first approved in the 90s for prediabetes, type 2 diabetes, and I am pretty aggressive with using it. And this is a study that sort of just was put out by Cornell back in 2021, but it showed that metformin use, even in patients without type 2 diabetes, so euglycemia is in blue, patients with type 2 or pre-diabetes are in red, but those patients who were on metformin for over 12 months lost an average of 7.4% weight. Without diabetes, compared to 7.3% with diabetes. So the point here, and if you can see over, 12 months, there was a significant proportion of patients who lost more than 10% of their weight. So what I will say is that metformin is a drug. It is generic. It is cheaper, and it does work. And I've had a lot of good benefit from it. And so there are a lot of patients who may not qualify for other drugs where I do suggest a trial of metformin. And I can also help in the future if they have any form of prediabetes. One, I guess, sort of trick I've used is if you start them on metformin, you follow them up, their A1Cs are still in the prediabetes range, 5.7 to 6.4, that can help them get an injectable covered for Medicare, Medicaid by indicating, or commercial insurances saying, hey, this person has an A1C, it's still elevated on metformin. This is diabetes spectrum. They could be having an A1C over 6.5. Therefore, they should qualify for Ozempic or Mounjaro or one of those medications. So that is one route of getting some of the injections covered for patients with Medicare and Medicaid.
There's a question about the starting dose of metformin.
Oh, sorry, I didn't see that.
Okay.
So yeah, I usually start, standard 500 XR, 500 to 750 XR, one pill. I usually start it with the bigger meal of the day. So whether that's lunch or dinner, and then I work my way up. So start one pill, after about a week, work up to 2. Technically, after 4 weeks, they could be up to 2,000 milligrams a day if they want to aggressively up titrate. For others, I sort of say start with 1, go up to 2, follow up in 1 to 2 months, and we monitor your progress. But yeah, usually I prefer extended release metformin if I can get it, and start with slow and steady. And the idea is we hope that metformin can help curb cravings and curb appetite, and help. And obviously, in terms of side effects, I do counsel them on risk of bloating, risk of stool changes, but most patients do pretty well, and obviously staying hydrated. But yeah, I think that's sort of where we start. The other medicine I want to briefly mention is phentermine. So phentermine is sort of what we consider a first generation medication approved in the 60s. It is an amphetamine, but in certain patients, it is really does well. So it comes in different doses, 8 milligrams, 15, 30, and 37.5. I usually start at the 8 or the 15. And to be honest with you, I really don't go past that. I might give the 30 milligrams once they've done all of these for maybe 3 months, 6 months max, but I never have a patient maintain the 30 or their 37.5. And it's more for data. We don't have a lot of clinical data or research studies using these higher doses. All of the studies mostly have been done on the 15 milligram dose. So phentermine was first developed. We don't have, like I said, we have a lot of short-term studies, not a lot of long-term studies, but in patients who don't have uncontrolled hypertension, who don't have heart disease, these drugs are safe. And what we know is that, yes, for short term, there was initial thought you can use it short term, 3 to 6 months, potentially taper off of it. I have used it also in patients who potentially want to conceive in the future, who just need that boost. I've given it for 3 to 6 months, said, okay, we have to stop it, obviously, at least 1 month before you start trying to conceive. But we've seen it do well. Patients do, in terms of response, feel that benefit. They feel that boost of energy. They feel that appetite suppression. Obviously, if they note increased heart rate, palpitations, insomnia, we stop it immediately. There is some thought that, yes, we shouldn't use it long term, but In a patient who's tolerating it well, who's responding, who doesn't have any adverse effects, we have some patients who wanted to continue on it. And that's where sometimes what I do is I start the phentermine after 3 to 6 months. If they want to continue more of a long-term use, I sometimes add topiramate to it, and I'll talk about that combination next. Um, so phentermine topiramate, the brand is Qsymia. It has been approved since 2012. And this is a medication which, if you get the brand Qsymia, you start at a very low dose, 3.75 milligrams of phentermine, 23 milligrams of topiramate, and then this is the titration. So you have a 2-week titration period, and then you go up. The reason I mentioned Qsymia is that one, it is a pill, so some people prefer a pill. It is safe. We have data up to 3 years showing clinical benefit. And the doses, is very fixed. So, you start, you go up. If you're not responding with weight loss, you can go up on your dose. Adverse side effects, increased, heart rate, palpitations, insomnia. If they're on the topiramate, some people have mentioned numbness, tingling, sometimes sleep disturbance, but really otherwise well tolerated. And so I was saying earlier, you can get this medication Qsymia through the pharmacy. If it's covered, obviously great. For most patients, it's not covered. So what I typically do is if they're able to afford it for $95 a month, you can send it to the patient savings program. So Qsymia has a savings program. So it's about $95 per month through their patient engaged program, which is still a lot of money. So for some people, I do that if they can afford $95 per month, and you send it to a drug company called Medavantix, which mail orders the drug to them. Or if they can't manage $95 per month, I do separate into components where I give them 15 milligrams of phentermine and I give them topiramate starting at 25 milligrams at night, and then I titrate up. So I give them 25, then I go to 50, then I go to 75, then I go to 100. And so this combination has worked well, and patients have done really well. And I can show you the data. This is from actually 2012, but with Qsymia, highlighted in the triangles below, those who were on the max dose lost up to 12 to 15% of their body weight. So this is actually quite, significant. And from the clinical study, looking at percentage weight loss, up to 30% of people lost more than 15% of their body weight. So this drug has worked well, and there are many who prefer Qsymia or phentermine topiramate over an injectable. So I mentioned Qsymia as sort of more of a first-generation medication, but I do find it very effective. And for patients who don't qualify for injectables, who don't have coverage, using this as brand or in separation as generic pills can work really well. Jumping ahead to what we consider sort of our incretins, or you could say GLP-1s or GLP-GIP-1s, we've got Saxenda, which is liraglutide, approved up to 3.0 milligrams from 2014. And then we've got Wegovy and Zepbound. We've got our STEP trials with Wegovy and our SURMOUNT studies with Zepbound. And we have numerous ongoing studies with fatty liver, sleep apnea, heart failure, cardiovascular outcome studies, and even osteoarthritis. So again, very exciting times. And I briefly want to talk about some cautions with these drugs. So number one, pregnancy. None of these drugs have been tested in pregnancy. So what I do technically counsel a patient is if they're trying to or thinking about conceiving within the next year, they have to be off of it at least a month before they start trying. If they're going through IVF, definitely we want them tapered off. And it's not just a fact of them being on a medicine and stopping it. They do have to taper off of it because we know there is potentially a risk of abruptly stopping it and weight regain. Obviously, in patients who have history of severe gastroparesis, ulcer disease, or serious, inflammatory bowel disease. These are patients you want to be very mindful. If someone has, Crohn's or ulcerative colitis, if it's controlled and well controlled for many years, I will consider using these drugs. But if they're having active flares and they're not stable, these are not patients that I'm considering using these drugs. We don't have as many studies in type 1 diabetes, but I have a lot of patients who are using them, and in combination with their insulin, we've seen tremendous benefit. And I definitely have seen some beneficial studies there. And thinking about risk of pancreatitis, so we know ultimately this is seen with all injectables, whether there's risk of pancreatitis. I think it's controversial. I don't think so. I think these drugs really are sensitizers, helping with insulin resistance, helping relax the pancreas. But when a patient has a history of pancreatitis and the etiology is not known, so it's not alcohol, it's not gallstones, you really should not consider these drugs unless the patient really says, I've I want it. And I've had one or two of those where like, I know I had this, but I really want this medication and we'll weigh the risk. And then last but not least, thinking about any history of MEN or medullary thyroid carcinoma. Again, medullary thyroid cancer was only seen in rats. I do not recommend checking a thyroid ultrasound. I do not telling a patient, I really think the risk is minimal, and we haven't seen those studies being borne out, but something just to be aware of. Thinking about each of these drugs individually, so you got Wegovy, starting dose 0.25, so very similar to Ozempic. Every month you can titrate up, and then after 1 milligram, you go up to 1.7 and 2.4. These are considered maintenance doses. And, unfortunately, again, if commercial insurances are not covering the Wegovy out of pocket, this medication, I actually just talked to the rep yesterday. She said the cost is coming down, but it's going to be about $650 per month out of pocket with self-pay. The nice thing about the pen is that it is an auto pen injector. You're just literally pressing a button. And then this is a study with Wegovy. Again, the benefit, approximately 15% weight loss over 68 weeks. And I present side by side these trials. This is from the original step 1 and then the extension. So for patients who ask you, and I have many who come to me saying, I just need a reset. I just want to be on this drug for a short time and come off of it, and I will be able to maintain. We have clinical studies, and this is from actually 2022. 68-week treatment phase. Patients did really well. Stopping the medication, followed up, regain. And I could argue, if you follow this curve even longer, there will be continuous regain and potentially even rebound regain. So telling patients, and we're seeing this clinically, if you start this medicine, this is a long-term medicine, and you will need to continue it and potentially pay for it. Knowing that there are newer studies. So this is a study just done in 2023 looking at fatty liver disease. So the idea that these drugs do help with MASH. They're still concerned about whether they help with fibrosis. We know that they help metabolically, which indirectly can help with liver disease, but definitely growing data in the setting of the liver disease spectrum. And then more recently, last fall, Wegovy was tested in patients with heart disease and showed 20% reduction in patients with overweight and obesity. So this is really huge data showing reduction in the risk of cardiovascular events. And the reason this was so important is, number one, this is stronger data than use of statins, than use of baby aspirin, but it has pushed Medicare to cover, and some Medicares, I should say, to cover Wegovy. So in certain patients who have active heart disease with atherosclerosis present, it has to be atherosclerotic heart disease. If you document that in the setting of having BMI over 27 or over 30, some Medicares have been covering Wegovy. And I've been seeing this. It's been challenging, but I have been seeing this. So that is why this data is so crucial. I'm going to jump ahead as we move through time to Zepbound. So Zepbound is tirzepatide, starting dose 2.5 every month you go up. And then just so you know, the maintenance doses, you can maintain 5, you can maintain 10, or you can maintain 15. So these are considered maintenance doses, meaning the insurance won't give you a pain if you want to continue that dose. But if you tell a patient, oh, I want to stay on 7.5 for months and months, the insurance will give you a little pushback. So thinking about Zepbound and then looking at the studies with Zepbound. So this was SURMOUNT-1, followed over 72 weeks and from 2022. So you can see the big number, and this is a little bit small, but up to 20% weight loss over that time period, which is extremely significant. And what's even more important is that those who lost more than 10 or 20% of their weight. So if you look at that, those who are on max dose, 83% of them lost more than 10% of that weight. So that's tremendous. And when we think about what our goals are, even looking at 20% weight loss, more than half of patients did. So again, showing the benefits of Zepbound and how it works. But I also want to point out, again, the idea that these are chronic long-term medications. This was actually published last year, showing that as patients are on the drug, great. You see this curve coming down, they're responding, they're doing well. At 36 weeks run-in period, a group of patients stopped the drug. As you can see, those who were transitioned to placebo regained up to a third or more of their weight. And again, I could argue if you continue this curve even more, you will see that weight come back and rebound. Growing studies again in the liver space, the same studied in the Synergy MASH trial, showing benefit with MASH, again, without worsening of fibrosis. And then the big trial, which I mentioned, we talk about Wegovy and heart disease. Well, the big update was just a few weeks ago when the FDA approved Zepbound for sleep apnea. So there was a reduction in apneic events, and given the significant data, which was done in 2 trials, one without patients on CPAP and with patients on CPAP, FDA decided to approve it. What does that mean? The hope is that this is going to put pressure on Medicare again to cover Zepbound for sleep apnea. And I've been told, even as of this week, that there are some insurances, Medicare specific, that are going to potentially approve this for sleep apnea. It has to be moderate to severe sleep apnea, and you have to document the obesity as a BMI over 27. Okay. We also have next generation medications. These are just sort of a summary. We've got pills, we've got injections, we've got double, triple injection combinations. So there are numerous drugs coming out. I'll mention oral semaglutide. So you may be familiar with oral semaglutide as Rybelsus for diabetes. What we do know is that oral Rybelsus has worked well in diabetes. There are a lot of side effects. This was a study from 2023 where they actually had patients on doses up to 50 milligrams. They were followed up to 68 weeks, and you can see highlighted in the blue squares, average weight loss was 15%. So that's pretty impressive. A lot of side effects, up to 80% of those on treatment had side effects. So something to think about. It has not been, despite these studies, it hasn't been marketed, it hasn't been FDA approved, but based on this data, likely within the next year to 2 years, oral semaglutide will be coming out as a weight loss medication. And then thinking about other drugs, there are small molecule oral GLP-1 agonists. So this was a drug called orforglipron. This was studied across many doses, 12, 24, 36, 45 milligrams. And again, big numbers, 15% average weight loss at the highest dose over 36 weeks. And I think even bigger, that almost half of the participants lost more than 15% of their weight. So again, thinking about what are our goals, this is a pill, not an injection, that has shown benefit up to 15% weight loss, and with mild to moderate side effects. So again, within the next, I'm going to say 2 years, some of these drugs may come to light. The newest one is this combination of cagrilintide semaglutide. So this is actually studied with type 2 diabetes and obesity, but cagrilintide actually is Similan. We use it for our patients with diabetes, type 1 especially, to help with insulin resistance. But this is a study actually done last year where they randomized patients with diabetes to this medication. And what they found was not only was there a significant 2.2% reduction in A1C, which I've highlighted in red here, but there was a significant 15% reduction in body weight. So this is being studied in phase 3 trials for patients with obesity. And again, nothing in the next year, but potentially in the next 1 to 2 years, this drug will come out as an injection that is weekly for weight management. And last but not least, I will mention retatrutide, which is a triple hormone agonist. So this is a drug that works on GLP, GIP, and glucagon. These are 3 gut hormones. And this was a phase 2 randomized controlled trial, over 300 patients with overweight or obesity. And again, numbers wise, again, doses titrated, followed over protocol. The max dose of 12 milligrams, which is highlighted in the blue squares at the bottom, you can see a weight loss of up to 24%. So significant weight loss at the max dose, even more than Zepbound or tirzepatide. But I want to also be clear, again, GI side effects up to 94% of patients, and obviously improvements in metabolically and prediabetes and whatnot. What they also mentioned is that almost 26% of patients here highlighted at the bottom lost more than 30% of their body weight. So I think of all of them, retatrutide, which is a triple hormone agonist, will be a true game changer. And again, not potentially going to come out for another 2 years or more. A lot of questions to be still answered. I know I could go on more and more slides, but I thought I could just address some of these briefly. Number one, we didn't talk about this, but drug shortages. A lot of these drugs have had shortages, both for weight management, also diabetes medications have had shortages. We think they're improving. Lilly and Novo have been working on this. There's also some concern about risk of gastroparesis, risk of aspiration. How does that affect patients who are undergoing surgery? So in the past few years, Mount Sinai has required patients to stop if they're on any sort of injection for at least a week, sometimes more as for some patients. The recent consensus statement that came out last month in November 2024, excuse me, suggested that we need to take a more individualized approach to this, meaning that some patients could potentially continue on their injections if they really need it. When we're still having ongoing conversations with anesthesia, how this can be incorporated and if this is going to be incorporated. But at this point, it sounds like they're still thinking holding a dose interval, one dose prior to any surgery. There have been some thoughts about potential risk of suicidal ideation. No causal association has been found. And then we talked briefly just about access and thinking about first generation, second generation medications. There are many commercial insurances that are putting up barriers here and restrictions. And as I said, Medicare and Medicaid do not cover these. But with this recent data and with growing studies in the liver disease space, with sleep apnea, with heart disease, with heart failure, and even with knee arthritis, there's going to be a study with knee osteoarthritis coming out in the next year. I do think that once we get these individual approvals, that puts pressure on Medicare to cover them. But in those situations, you do want to consider medications like metformin, medications like phentermine, topiramate, which can be generic. And if they have any form of prediabetes, these are patients where I start metformin and then again, I document A1C 5.8% on metformin, max therapy. This is equivalent to type 2 diabetes. This is a person that if they have Medicare, they don't qualify for a weight loss medication, but I can potentially get them an Ozempic or Mounjaro covered based on some of that documentation. And I forgot to mention also just the role of weight maintenance. Again, another interesting growing topic in the field. We talk about exercise, and my real message to all my patients is strengthening and toning. So once they even start in medicine, it's even more crucial that they are incorporating at least 2 to 3 days of strengthening and toning, and that they're also potentially increasing their protein intake. And there was this paper that came out last month talking about nutritional considerations and that patients who are on these medications should increase their protein intake to up to 1 gram per 1.5 grams per kilogram of body weight. So that is a lot of protein per day. But these are some of the guidelines that have been said and suggested. We still need, these are theoretical, we still need clinical studies to look at what is the real percentage of weight loss coming out and how do we really address that and how do we help patients maintain weight as they're on their journey. So with that, I'm going to close. Actually, I forgot one more slide. For patients who come to me who clearly either don't have coverage or failed medical therapy, yes, there is benefit to bariatric surgery. And I would argue that bariatric surgery is still a permanent option for weight loss for patients with BMI over 35 with complications or BMI over 40. So this is really crucial because we know that with bariatric surgery, patients can lose up to 30 to 50% of their body weight. So there are some patients who may also do better with surgery. What's also important to note is that with any intervention, whether it be medication, whether it be surgery, that most significant weight loss is occurring in that first 12 to 18 months. After sort of that period, we see patients sort of plateau, reach that sort of place where their weight is stable, and there is a risk of regain with bariatric surgery, as you're aware, and with all interventions. So just keeping that in mind. With that sort of, I'll sort of summarize. So again, sort of what are our goals? We are moving towards approaching this more in a weight, from a weight perspective to more of a complication-centric approach, targeting those patients who have more aggressive complications to have more aggressive therapy, whether that's medications or surgery, and sort of targeting patients that way. So with that, I'll summarize. Again, we know weight management is a very complex disease. I know this is a bit of a whirlwind. I tried to cover what I could, but I want to make sure we can address questions. We want to make sure that our management parallels the severity of the disease. And we understand this is a chronic disease. It's not the kind of one and done, you've lost this weight, you're good. We need patients, they continue to see me. Even when they've lost that weight, they're seeing me every 3 to 6 months for monitoring because there's always that risk of setbacks, things going the wrong way. We know there are new medications that are coming out that have tremendous potential, but I don't see anything foreseeing anything for the next 1 to 2 years, and definitely a lot of challenges. But we hope that with more data and more therapies and more studies, that we can improve access and improve treatment. So with that, I will end and I will leave room for questions. Thank you. I think there actually are a few.
Yeah, if you can go into the queue there.
Let me see here. I see. Okay. So should I look at chat or should I look at
Well, there's only one question in the chat is in
Okay.
terms of maintenance of weight loss. Do you see that one?
Yes.
Okay.
So, in terms of maintenance of weight loss with Wegovy, is there any evidence for less frequent dosing to reduce cost to have achieved their goal weight? So yes, and that's something I didn't address. So if patients are on a medication as they approach sort of their happy, I sort of say happy place, where their weight feels good, we do start tapering their dose. So in some patients, I start lowering the dose. For example, with Wegovy, I lower to 1.7, or I could continue on them 2.4. What I start doing is widening the interval. So we do start doing injections every, I say every 8, 9 days, every 10 days, over a few months, every 12 to 14 days. So gradually, the idea being is that you are widening that interval. So they are taking, it's less frequent dosing, but it's also a way of lowering that dose because the average, that they're taking in is much less. Keep in mind, though, that I have had some patients who have done really well with that widening interval dose, but I've had a lot who have sort of said, hey, I stop the medication, it's out of my system a week later, and then I give it to me. I'm sorry, I inject myself every 2 weeks and I get like this jolt and I feel really sick that first 24 hours. So there are some patients where just because of the half-life and the pharmacokinetics, they still feel it even more actually when they do the every 2 week dosing compared to every 7 days. It's something to keep in mind, but for some patients, it's worked really well. And in those situations where you're trying to widen the interval and they're still feeling a lot of side effects, then I start lowering the dose. So that's sort of one thing I do. Um,
Okay, well, let's jump to the Q&A then,
okay.
where most of the questions are.
Okay. Oh boy. Um, okay. Okay. So I'm going to go one through. I'm concerned about phentermine due to its being controlled. Do you encounter concerns with this addiction? So I would say I don't. I've used phentermine. Even I had a woman in her 70s yesterday who was on phentermine topiramate. Who's done really well. So I think it's really looking at your patient. You're seeing them, you know them. If there's someone who you think has potential for addictive behaviors, probably not a good idea. But I would argue that it's worked well. And yes, it is a drug that can be stopped and started. So that's why I like it. It is cheap. But I personally do not have a lot of concerns, and I have used it more long term. But I tend to, over time, I tend to only use the lower doses, 8 or 15 milligrams. I don't use the max 30, 37.5 much at all because we don't have studies. And I also, over time, if patients are on it, I try to negotiate adding topiramate. The studies with Sequel and with some of the other studies with Qsymia were actually up to 3 years. So we have data up to 3 years with phentermine topiramate. So over time, I do try to counsel these patients that are just on phentermine. Like within 6 months, I'm saying, hey, can we add topiramate? We know from a safety perspective, this combo works really well. And they're okay with that. Next question. What are your thoughts on Contrave? So yeah, I didn't talk about Contrave here. I do use Contrave specifically in patients who have sort of overeating or binge eating behaviors. I found that in terms of weight loss outcomes, from the clinical studies, average weight loss 10, 12% max. So potentially not as strong as Qsymia, not as strong as the injectables, but I have seen benefit. And just so you know, just as Qsymia can be separated into phentermine topiramate, Contrave can also be separated. So you can separate, give Wellbutrin, 150 milligrams up to twice a day, and then you can give the separate naltrexone component at night. So that is another way that I separate it out. Next question. How long is long term? I'm not sure what long term, I don't maybe know the context here, but long term meaning forever. If we talk about injections, long term means you have to be on this drug potentially forever. And yes, they're going to create new drugs, maybe that are every 3 months, every year, who knows. But I've been doing this since now. I mean, we started growing this in 2015 since I started. And I've had so many patients who start on a drug, lost to care, and yes, they're trying their best. It's not as if, life happens. And within a year coming off drug, that weight is all back, and there's more. So I've seen these sort of rebounds over and over. So I would argue if they're on an injectable, they need to potentially, be aware it's going to be long term, forever, maybe, unless there's pregnancy or other things in the near future. And if they're on something like a phentermine topiramate combination, a Qsymia, yes, they can stop and start it. But even then, any intervention I give a patient, there's always a chance, it's going to come back when I stop that drug. Just like depression, just like any other intervention when we give someone for a health condition. Um, Next question. Are there any considerations you would have for adolescents or peds? So I am not a pediatrician. I do see patients over the age of 16 technically, but a lot of these drugs have been approved for weight loss. I think the focus, and Joan Hahn is the head of pediatric endocrine here, who is also focused and NIH trained in obesity. So she has an obesity focus here. She is the best probably to address that, but there are a lot of protocols and there's a huge emphasis on lifestyle first, is my understanding in the peds world. So I would emphasize lifestyle first in the pediatric world, but if things aren't moving within that first, year or so, yes, we should be more aggressive. Is it 1 gram per kilogram or of ideal body weight or their current weight? I'm assuming this is for protein intake. So I would say for protein intake, I usually use their current body weight. So if they're, 60, 70 kilograms, I'm potentially recommending protein intake up to, 60 to 80 grams of protein a day. Okay. Can I share slides? I will defer that to you guys.
Yeah,
I
all of our grand rounds are put on our website afterward.
okay.
And
Okay,
so people
wonderful.
can look at them anytime.
Okay. And then, I answer the question. Like I said, I'm not a pediatric, but again, for geriatric patients, I think these are patients treated the same way with Medicare, Medicaid. Again, drugs are not covered, but we are using these medications. And I forgot to mention, I should answer this, but just in the last month or two, for cost savings, Wegovy, as I said, is $650 per month. Zepbound out of pocket is about the same for the pen injector, but there is a vial of only the lowest dose, the 2.5 and the 5 milligram of Zepbound. If you buy it through their website, Eli Lilly Direct, you can get the vial of Zepbound of 2.5 milligrams for $3.99 per month. Still a lot of money, but I've had some patients who've been willing and wanting to do that with Medicare. And that cost of $3.99 per month is for anyone. Okay. How would you recommend incorporating measurements into your primary care? I would say the easiest would be to start with waist circumference. Yes. So getting a waist, a tape, measuring that, tracking that. I think it's really important. I've started doing it. I wish I could train my medical assistants to do it for me, but I think it's really important. And patients see it, when they're measuring their waist, their clothes. For younger patients with BMI over 40, isn't bariatric surgery more cost effective than a weekly injection? I would argue, I don't know necessarily for younger patients, but I would say just generally across the board, if patient has a BMI over 40, yes, surgery is more weight loss effective. That is a fact because of the duration of needing these medications. I agree with you, and that's why I argue bariatric surgery is a more permanent option. Okay, what about the patients on long-term antipsychotics? Can they take them long-term? Yes, for sure. No interactions with antipsychiatric medications whatsoever, very safe. How does the topiramate make phentermine safer? It's more because of data. So we've got clinical studies up to 2 to 3 years showing clinical benefit. We do not have any data with phentermine on its own more than 6 months, 12 months. So that's what I mean by safer, meaning we have long-term data supporting the benefit and safety. But at the end of the day, as I said, I still have some patients who've been on phentermine low dose for potentially up to years, who have tolerated it, who have no contraindication, and that's sort of their belief. And then last question, what are about all the compounded forms? And so I personally, this is a very challenging question. I'm not actively prescribing compounded forms of these drugs. I do appreciate there is a need for them because these drugs are not covered by many insurance types. And I would sort of leave it on the patient if a patient really wants it and has a place in mind that they're going. For example, patients go to Weight Watchers or Row or Hims or Hers. And if they really want to and we're not able to do it in all the legal ways that we try, I will defer to them. And they can do what they want, and if that's what they need. But I have personal concerns about the safety. We know that these are compounded. They're coming from the salts from Asia. We don't know what's exactly in them. We don't know what's added to them. And my concern, because I've had a lot of, especially young women who've come to me where they're just not being monitored closely. So the concern is that there's not a lot of close monitoring with some of these virtual programs. They're getting the drug, they're filling out a survey every week or every month, and there's no question about how do we address your weight, how do we address your stomach, how do we address your constipation. That sort of following is not happening. And so my concern is I've had a lot of patients with very severe side effects, nauseous in an ER, throwing up for 36 hours because their drug was dosed inappropriately. So I do have concerns about it. I don't actively prescribe compounded forms, but I appreciate it is a very very tight space, and there's a very, I mean, a lot of controversy around it and challenges. And I think our healthcare system is not great with getting these drugs covered. How do you help
I,
prepare
I,
patients?
yeah, just just one question before we run out of
Yeah,
time.
I know.
So, the weight and metabolism management program. So you're talking to a group of people who are in primary care.
Yeah.
What's the best way for people to if do you have a program where people can send folks for an initial consultation, but then be managed by their primary care folks? Do you interact, or is it, the referral and then people are managed by your program, in an ongoing way? Like
Yeah,
how
so
can it work?
essentially, I mean, I would say yes, in a way to answer your question, it is a referral. And then, myself, we have, I mean, most of the endocrinologists within our group on 5 East 98th Street are doing some form of weight management. We have a nurse practitioner, we have a nutritionist. We also have, I don't know if you're aware, at Sinai Morningside, there is the Mount Sinai Physio Lab. So the Mount Sinai Physio Lab at 114th in Amsterdam does offer exercise counseling, body composition testing, even exercise testing. It's out of pocket, but it's a resource and it's unique to Mount Sinai. A lot of places don't have that, and so that's something it's not insurance covered, but for patients who, are very, very active, who want that sort of extra, how do I improve my fat burning, or how do I optimize my exercise? That exercise counseling can be really helpful. I think Hannah. I'm blanking on her last name, but she's great. She's an exercise physiologist. She's the director of the Mount Sinai Physio Lab. So definitely, we can help with the referrals. There is, I think, as you know, there's a growing need, and I think that it's tough for us to see every single patient. But I do think that if you see a patient, if you start them on something, get them going, and then refer them to us, we're happy to help. We're happy to give input. I think that's sort of the best way. But no, I don't have like a specific program there. I don't use meal replacements. I'm not, doing any of that. So it's more just individualized physician care.
Red?
Yeah, I had two quick questions. This is great, thank you. One is, do you see a role for continuous glucose monitoring, considering how popular that? Just comment on that. And the second is, are there elective opportunities for our residents to actually spend time with your team? And if not, would you be interested in helping us establish something like this? Because I could see this being a really, obesity medicine being just a real important part of our training program.
I agree. No, I agree. And I think we've established with our endocrine fellows, they do have to they actually work with me for 6 to 8 weeks in their second year. It's a requirement. So they shadow with me and some of the other sort of obesity providers across the Sinai system. So we don't have anything sort of formally set up with family medicine at this point, but definitely happy to talk about it and have a conversation about it
Great.
for
Thanks.
sure. And then you mentioned continuous glucose
CGM.
monitoring. So yeah, actually, so my study with Dexcom was an investigator-initiated study where we gave patients a continuous glucose monitor, and we tracked them for 3 months, and we were following them for weight management. So patients had a BMI over 30, and I haven't presented the data. I'm writing up a manuscript now, but we did find, I mean, people liked it. It provided changes. The challenge is it's not going to get covered by insurance, but it was helpful. So it might be something to think about, in the future. But definitely not covered yet. And I think the fear and the concern I only had is when I did the study, there's a lot of like fluctuations in sugar levels that can occur. And someone who doesn't have diabetes, that can be very scary.
Yeah,
So there are a lot of like messages late at night being like, my sugar's 180. I just ate this. What do I do? Is this normal? And these are patients without diabetes, mind you. So it's just like a lot of it was user savviness. Some of it was just learning some about, what these numbers mean. But I definitely think it can help in a certain population. Yes.
great. Thank you very much. Appreciate it.
Okay.
Great.
Wonderful.
We're at the top of the hour, and there are some more questions. Do you have a few more minutes to answer some? Or if
I have
not,
like one more minute.
okay.
Let me see, because I
How
have.
do you help prepare people for bariatric surgery?
So, I mean, essentially, most of the patients who I refer to bariatric surgery have already been trying their best working with me. So I think essentially it is essentially lifestyle management, using medications as much as we can. And then, yes, I think going through the surgical process if things are not moving the way they should. So,
Great.
uh,
Well, I'll just end by saying thank you. There's obviously an amazing amount to think of. I think, thinking about this as a lifetime, long-term, chronic disease, and it really really changes the way people have thought about, right? You lose weight and then, wow, that's great, I lost weight. But what you showed is no matter how you lose the weight, it seems to come back unless you think about this as managing a chronic lifetime illness. And
Very true.
that, you know, that really changes the way people think about this, and especially the way the general population thinks about this, right?
Yes, exactly.
Well,
And I think it
yeah.
just starts with recognizing it, looking, when you see the patient in the office, addressing it. And I think it's really important. Yeah, it is a chronic disease.
Well,
for sure.
thinking of this as chronic and lifetime, could you come back again? And because I think, this is obviously a field that's expanding with new information. And I think this is just such a helpful opportunity to start this process. So if we could impose upon you for next academic year.
Of course, no, happy to help. And hopefully we'll have updates then. I don't know.
Yeah.
I think,
And work on the elective. I think that would be great.
sounds good. Sounds good.
Okay.
Thank you so
Thank
much.
you.
It's really great talk. Thanks so much.
Thank you.
Thank you. Have a great day.
Thanks, everybody.